afternoon, everyone, and a very warm welcome for this webinar, which is hosted by the East Delhi Gynae Forum. Today's webinar is on recurrent pregnancy loss. As we know, spontaneous pregnancy loss is a common occurrence with 15% of all clinically recognized pregnancy resulting in miscarriage. And recurrent pregnancy loss, where 3 or more pregnancy loss occurs almost in 1 to 2% of women. Spontaneous pregnancy loss can be physically and emotionally taxing for couples, especially when faced with recurrent losses. It is as well as frustrating to the treating clinician also. So what is the best course of management of couples having RPL? We get to hear from our mentor and teacher of teachers, Dr. Sharda Jain ma'am, today. The topic is tender love and care in recurrent pregnancy loss with progesterone. And we have our experts with us, Dr. Uma Rai. Ma'am is a patron of East Delhi Gynae Forum. She's a retired professor of Lady Hardinge Medical College. And Dr. Mala Srivastava. She's the immediate past president of AOGD, senior consultant at Gangaram Hospital. Dr. Sangeeta Gupta, vice president, Delhi Gynae Forum and HOD of ESI Sadarpur. Dr. Seema Sehgal, she's the advisor of DGF North. She's senior consultant OBGY at MKW Hospital. Dr. Anjila Aneja, she's president DGF South. She's director and head minimally access surgery Fortis Gurgaon. Dr. Surjeet Kapoor, senior executive member East Delhi Gynae Forum and director Kapoor Hospital. Dr. Mamta Mittal, ma'am is president of DGF North. And now we move on to our academic session. And I request ma'am to please start the session.
Thank you, Dr. Meenakshi. Today I'm going to a subject which is hardly ever talked. And I will have 2 parts of my presentation. The initial part will be of 5-6 minutes. That's for general people, whosoever is listening us. And second part is the academic part of it, because these presentations are watched not only in India but in the neighboring countries as well, and we get a feedback from there. So I have separated it. So just give me a minute. I do the share. A couple of slides have been given to me by my friend, Dr. Surjeet, who is also an expert here. So, due regards to my experts in this particular group, who had been my colleagues and the great academicians, and I thought, the topic which I'm touching, they will share their own experience and enlighten the people who are watching us. Recurrent pregnancy losses, managing the unexplained. My boss, when I joined the institution, PGI Chandigarh in 1970, she used to say that from her personal experience, she can say that a patient with unexplained RPL, that is tender love and care, can surprisingly give positive outcome. And it was almost 2 decades later, tender love and care became part of the textbooks, where the 2-3 lines were always mentioned about this. I think healers has that particular gift that they can, beside giving state-of-art care, can really heal with their eyes, with their hands, with their touch. The happiest people in life are the givers and not the receivers. जिंदगी का सबसे खूबसूरत एहसास होता है किसी की खुशी का कारण बनना. And I think the doctors knows the best. Whether the doctors get money or not, but the kind of things which are secreted in a system that make them happy all the time. We rise by lifting others. That's an old saying, and I think we practice day in, day out. And when it comes to patients, it also makes so much of difference. But you can only give when your cup is full. That means spiritually you have to raise your vibration to a higher level, and then only you can pass it on to your patients, the positivity and the goodwill. God is still the best doctor, and the prayer is still the best medicine. It is for both doctors as well as for patients. And the art of medicine consists in relaxing your patient, in amusing your patient, while the nature cures the disease. And this is the story of a small boy and the horse. They were great friends. One day they had gone for a long drive. And then this storm came, which bothered this boy. And he said, "This storm is making me tired." So the horse said, "Storms is also getting too tired. Just hold on. Another few moments, things will pass on." And this is what we have to do for this patient who is depressed, has to be counseled just like this horse who says, "Hold on, good days are coming." Let's carry hope by tender love and care, and act like an elder bird who guides the younger one while she builds a safe place to nurture her own baby. The plight of the victim of RPL is that she's crying, depressed all the time. 3-4 days back, I had a case. This lady has had a blighted ovum, and this time, second time when she was pregnant, she got 4 ultrasounds done over a 3 weeks period. 3 times HCG was done in the false hope that the fetal heart will come. She's not only depressed, her husband is also equally upset. And these 2 lines make all the difference to her. She picturizes the child, the future of the child, and when if things do not materialize, when she does not get to meet the child, when she does not see the child, she is definitely shaken. What is your role as a healer? We have to only say, "It'll be all okay." Relax her. Inhale confidence and exhale all doubts. I always say, डर और ट्रस्ट दोनों साथ साथ नहीं चल सकते. डर हटाना पड़ेगा तभी ट्रस्ट आएगा 100%. You have to give lot of time to your patient, good listening, great support to both husband and wife. Kindness, empathy, concern, and compassion are the buzzword. My daughter, who's a psychiatrist, says, there are no quick fixes to grief, no easy answers. Every expression of grief that you want to be fixed has to be honored, has to be given a space, and you have to ask your patient to spell it out. What does she feel in terms of emotions? And then only it will get healed, otherwise not. Sometimes a ray of hope is all the sunshine you need. डूबते को खाली एक तिनके का सहारा चाहिए. You have to make her strong. You have to make your patient brave, positive, healthy, and give her a confidence she can handle everything, even if this particular pregnancy sees through the end or not. So when she's standing and enjoying the nature, it does not mean she's alone. It means that she's strong enough to handle things by herself. But at times, even if she feels very strong person, every now and then, she says, I need someone to take my hands and say, everything will be all right. Doctor's role is to relax the patient. And that's only possible that you give her good listening, give her a time, tell her that I am just a call away. And love really conquers pain. Togetherness with the doctor and togetherness with your partner makes all the difference. And sometimes the most ordinary things could be made extraordinary simply by doing them with the right people. With these words, I will go to my second presentation. Surjeet, thank you very much. Coming to my main presentation, Tender Love and Care in Recurrent Pregnancy Loss. I will touch upon the pregnancy loss, definition, prevalence, the psychological impact, talk whatever is available in literature on tender love and care, and then I will definitely talk how patient can benefit by adding progestinogens and few take-home messages from my side. Now, coming to the pregnancy loss, we all know that each menstrual cycle yields conception up to 30% of time. And we all know that a pregnancy loss is a common and often remains unrecognized. Of those conceptions, nearly 50% will miscarry. The pregnancies lost prior to implantation are clinically unrecognized. But after implantation, the rate of pregnancy loss decreases. Roughly a primigravida and count as 15% of pregnancy losses in the first trimester. And it is said that 25 to 30% of the couples attempting pregnancy will show sporadic miscarriage. As for the incidence of recurrent pregnancy loss is concerned, if we take 3 consecutive abortions, roughly the incidence is around 1%. But if we take 2 consecutive losses in account, the incidence is around 5%. And nearly 80% of the pregnancy losses cases occur right in the first trimester, and very small percentage is there in the second trimester. This is a very interesting slide. It has always fascinated me. But that brings home that the best age for producing a child is between 20 to 25 years. At that time, you have a least pregnancy loss, which is around 10%. At the age of 30, it is around 15%. At 35, the pregnancy loss is around 25%. At 40, it is 50%. And after 45, it is nearly 100%. If we take the definitions, the European Society and the Royal College of Obstetrician Gynecologists refer RPL to 3 consecutive losses, including the non-visualized one. While the American Society of Reproductive Medicine defines 2 or more clinical pregnancy losses documented by ultrasonography or by histopathological examination, and according to them, it may not be necessarily consecutive. Ectopic and high dentiform mole are not part of the recurrent pregnancy losses. It is said to be primary whence there is no history of pregnancy going beyond 24 weeks of gestation prior to this, and secondary when there is a history of 1 pregnancy at least going beyond 24 weeks of gestation. I'm not going to dwell on the etiology part of it, but we know it. The Western world literature says that nearly 40 to 50% cases, in spite of your best efforts, the cause remains unexplained. The main causes are A+ syndrome, the uterine anomalies, uncontrolled diabetes, uncontrolled hypothyroidism, and parental chromosomal abnormalities. Gynecologists in India definitely blame tuberculosis as one of the causes of recurrent pregnancy losses. But now I find lately in 2020-21, whatever the presentations have come, and they have very categorically said the chronic endometritis causing any of things cannot be the cause of recurrent pregnancy loss. The immune system is the body's brain. Whatever it recognizes as self, it leaves it alone. Whatever it recognizes as a non-self, that is destroyed. Sometimes it misidentifies. So on one side, it gives rise to autoimmune diseases, and at the same time, this recurrent pregnancy loss is also a problem of misidentification by your immune system. The psychological impact of recurrent pregnancy losses are great. The WHO says the health is a state of a complete well-being, physical, psychological, and social, and not merely the absence of disease. But it is the mental health which makes a woman that she can deal with her normal life stresses, she can work productively and fruitfully, and she can help the society. The common mental problems seen are the anxiety, which is transient, but it can create a havoc in terms of adverse events, including abortion. The stress is when you feel danger is perceived by a person in the environment. It can be chronic. And depression is, they are symptom complex. And that is presentation of a low mood, low activity, and low energy. The limbic system of brain is the seat of emotions. And what is the limbic system? The hypothalamus, hippocampus, and amygdala. But emotions directly go from thalamus to amygdala, bypassing the cortex. And that is why emotions have their mind of their own, quite independent of the rational mind. And this goes irrational. And is man ko jeetna hai, and this is where the doctors and the healers have to chip in. The relationship between mental illness and how it affects the human physiology is the stresses work through the pituitary. There's a copious discharge of ACTH from the pituitary. It in turn stimulates the adrenal cortex. There are a lot of corticosteroids, and that creates an enhanced inflammatory response, and which we now know is the cause of all the problems which we have. Fear and anxiety in the patient are manifested by many assurances which she makes to the doctor. She says, my biggest thought with each loss is what I have done so wrong to deserve this. I can't face the thought of another miscarriage, but I definitely want a baby. They did not find anything on investigations. Then why did I lose my baby? She says finally, for the first time when I got the 2 lines, when I saw, I was thrilled. But now I get scared to get the positive pregnancy test because I know that probably I will have a repeat performance. These traumatic stresses work on the emotional, they cause profound emotional impact on the woman and her partner. Loss of baby, all the hopes, all the plans invested in the child get shattered, and they have a sense of a personal failure, which is intensified with repeated losses. Depression and emotional stress are highly prevalent in this group, and the psychiatrists have their way of dealing with it. They call it post-traumatic stress disorder for handling anxiety and hospital anxiety depression scale for handling depression. And it has been found that these symptoms persist. They peak at around 1 month and they persist at least 3 months following pregnancy loss. In some cases, that can go on for months and years. Both men and women get affected by this anxiety and depression. Depression is said to be more in women in comparison to her male partner. And that's why the health professionals should screen for anxiety and depression and their social support for both partners and support them unconditionally. When it comes to treatment, all good clinicians have to always handle their patient with tender love and care, with state-of-art care which has to be given depending upon what has been the cause of the recurrent pregnancy loss. And as far as I'm concerned, I feel progestagens also help her a lot in seeing a full-term pregnancy. Now coming to tender love and care, this definitely there's a loss of communications lost between the husband and wife. And these negative emotions are toxic, just like smoking and alcohol. It does not mean that all anxiety will result in pregnancy loss. And it also does not imply that TLC will avert all abortions. Tender love and care, as just now I said, that I learned it for the first time when I joined post-graduation way back in 1970 in PGI Chandigarh from my boss. And studies have shown that significant impact it can have in the next pregnancy if you use tender love and care. And patient can be right in the beginning, can be assured that you can carry your baby to the tune of 70 to 80% provided you remain positive. If you remain negative, your anxiety and depression continues, then probably you have lost the battle. The evidence is level 3. It is not that robust, but it is not that bad also. But metaphysical healing coming through your healer is known to give a power of positive thought. What is the doctor's role then? Provide emotional support to both husband and wife. Compassionate VIP care has to be given. VIP care means they require a double or triple of the time, and they require extra care from your staff as well. The clear information must be passed on, nothing should be hidden, and a weekly checkup is the key. There's something called autosuggestion, which the psychiatrists name it as positive reappraisal coping intervention. In our country, there's not a policy to send these patients to the psychiatrist, but this is often done outside. Now, the weekly visits, the weekly checkups, the frequent scans, good listening, reassuring both husband and wife that all is well today makes lots and lots of difference. It goes to a step forward that you give them something like a leaflet where some auto suggestions are there, 8 to 10 in number, which she reads 2-3 times a day. And this, on a daily basis, recharges her on positivity. Less is said about these quiet and relaxing moments when you try to relax your patients. What does the patient want? Patient only wants one thing. Tell me something that makes me positive. I do not get back to negativity. I should see things in a very positive way. Look bright side of life. Try to do something meaningful and focus on the benefits and not just the difficulties. And I should be introduced to a couple of more people who have passed through similar experience, so I learn from their experience too. The psychological support in early pregnancy decreases miscarriage rates in women with unexplained recurrent miscarriages. And we all know, if the first trimester is crossed, 90% of your problems are over. Then tell her, ki haathi nikal gaya, khali poonch baki hai. So that way they get very assured that my 3 months have passed. I do teach my patients Reiki, and it definitely helps them. Whenever she's off mood, she cries, then, she's reminded of all the time. I tell them to put stickers around in their rooms about this Reiki, and they do it. Psychological support is, I told you, this is rubbed on a weekly visits and examinations. She's advised rest, though the literature says the rest does not do anything. She's also advised to have an abstinence. And especially she has to be careful 2 weeks prior to the gestational period at which she has had earlier miscarriage. Hormonal therapy, I'm fond of it. I can be guided by the experts who are going to speak at the end of my talk. Now, tender love and care, wherever it is practiced along with the medical treatment, gives in this particular study something like 80% positive thing to have a successful pregnancy. Where it is not used, the abortion rates are much, much higher. The question is asked whether one should have a dedicated clinic. I say that not only dedicated recurrent pregnancy miscarriage clinic, one should have a dedicated staff. Then only it is possible that the continuity of care is there and the patient feels relaxed in your company. And it has been seen that wherever it is practiced together, the pregnancy loss is much less, and nearly 70% achieve the live birth rate in the next pregnancy. I must remind everybody that the focus should be on both partners. You should try to mitigate anxiety by encouraging a feeling of trust in the expectant mothers and the husband. The partner support helps the woman significantly, is as important as the support from the doctor. Supporting behavior of partner of a woman with an RPL is very important. She feels very emotionally very nice when she says, he listens to me what I say, he engages me, he encourages me, he gives me more time and a quality time. And this probably makes her emotionally very stable and confident. And this togetherness helps in building a family after recurrent pregnancy loss. The psychological interventions, what is practiced in the West and here is pretty different. I can definitely say that you and your team gives a supportive therapy. You definitely give some tips of yoga and meditation and auto-suggestions. A couple of relaxation exercises can be told to them. And if there are a couple of patients are there, it is always good to have a group sessions, and these days with digital, you can have a group thing where auto suggestions and all can be taught. Now they can be self group helps available, but grief resolution, the gynecologist is not trained. This particular job has to be only done by the psychiatrist. ESHRE recommends that the recognition of the patient as an individual, not only woman, the couple, and even her past history, where the due recognition is given to the babies which she wants to highlight time and again. That you should give enough time to them for questions so that she should not grumble at all that you had not given her time. Good listening is required where she does 90% talking and you do only 10% talking. You respect the patient, the partner, and the clear, sensitive language should be used. One should not use a lot of science. Your talk should be emotional and no science. Honestly, you must explain to her everything, what is the chances of likely outcome, the prognosis, and avoid false assurances altogether. Shared planning and see to it that she definitely complies, she and her husband. Supportive care in the next pregnancy in the form of weekly visits and repeated scans. Kindness, concern, empathy, compassion are the buzzwords. Hoxie also recommends tender love and care as to achieve 65% of the results where no cause has been found for recurrent pregnancy loss. So in summary, the pregnancy loss is a significant negative life event. Repeated may intensify the grief experienced by the couple. Support emotionally both woman and the husband. Clinician and husband support is vital stimulus to the grieved woman. Now coming few slides on the right progestogens which we use. What does the evidence say? I think in the last 2 years, this must have been discussed about 12 times. I can definitely say that hormones are lower than the normal serum progesterone. and some say that they can be a luteal phase defect, and that is why there is a shift when you use progestogens. There's a shift from type 1 TH1 atmosphere to TH2 atmosphere. TH1, I'll say, is a pregnancy disaster, while TH2 type of environment is a pregnancy conducive. As for the formulations are concerned, I'm sure between the injectable, vaginal, and oral, if you take the choice of the patient, she prefers oral progesterone. And among the oral progesterone, it is oral dydrogesterone, which is very, very effective. Oral micronized progesterone is not effective at all, and nobody should ever use it. Both oral dydrogesterone and metabolites act conducively for successful pregnancy. There are about published evidence of 600 articles globally. As far as the oral micronized progesterone is concerned, there's a 0 published article, except one article has been from the GTV. The bioavailability is great, to the tune of almost 30% in comparison to less than 5% with oral micronized progesterone. I think all of you know about all these things. I'm not going to repeat it. I can definitely say what is the global guidelines recommendations about the dydrogesterone in RPLAs. European Progesterone Club says that for a woman presenting with clinical diagnosis of 3 recurrent miscarriages, there's a reduction in the rate of miscarriage with the use of dydrogesterone. The Foxy position paper clears it that the dydrogesterone should be used in the dose of 10 milligram BD till 20 weeks of gestation. ESHRE gives the guidelines very clearly that the vaginal progesterone during early pregnancy has no beneficial effect in a woman with unexplained RPL. There is some evidence that oral dydrogesterone initiated when the fetal heart action comes can be confirmed and may be very effective. What you need to know. So in the setting of complex background of RPL, the take-home messages are few. The psychological impact of RPL is enormous, affecting the mental health of the woman. RPL leads to depression in both, affecting the relationship with the partners. The supportive medical team, along with the continuous support of the partner, can significantly improve subsequent pregnancy outcomes. Tender love and its addition to medical therapy can lead to successful outcomes. The use of progestogen supplementation in reducing miscarriage rates is well established and supported by numerous studies. Oral is the most preferred route of administration by patient compared to the injectables and the vaginal progestogens. Dydrogesterone is only effective progestogens as compared to the oral micronized progesterone. But whenever there's a short cervix, I definitely like vaginal progestogens do magic in those cases. The use of dydrogesterone in threatened abortion, the dose is 40 milligram stat followed by 10 milligram BD. Dydrogesterone 10 milligram BD till 20 weeks of pregnancy causes significant reduction of miscarriage in recurrent pregnancy loss. With these words, thank you very much. Give me the patient hearing.
Thank you, ma'am, for the excellent presentation. We really do need tender, loving care for patients with recurrent pregnancy loss. I would like to invite the experts for their comments. Dr. Umar, ma'am.
Who wants to come first? Dr. Anjila?
Anji, no, I really enjoyed your talk, and I think, ma'am, you were very clear, and you have asked the comments from all of us about the role of progestogens in recurrent pregnancy loss. I always like to give, and especially I've started giving when Dr. Ashok Kumar from Maulana Azad, he has done a very good study on recurrent miscarriages with the progesterone. So I feel that was one of the best studies. It was even quoted by ESHRE. And this is our Indian study, which shows the use of dydrogesterone in a patient with a recurrent pregnancy loss is definitely, there is a good outcome. And they have suggested to give up to 20 weeks. So I'm also following that only in my patients with a case of recurrent pregnancy loss. And secondly, I think, ma'am, what you have said with the threatened abortion, initially we used to give the injection Proloton or a Susten injection. I think I heard Dr. Jyoti Agarwal lecture. I think we learn from everybody's lecture something. So I still remember when last year I heard her lecture, and I also started giving my patient 40 milligram dydrogesterone and then give once, twice a day. Patients have definitely shown
Madam,
it.
works wonders. Works wonders.
Yeah. So I feel every lecture is very important, even if we get one take home message. So that gives a lot of opinion. And Dr. Ashok Kumar's study was a very good study. And he gets 3 cheers for that study. Being an Indian study, it has given us a lot of hopes that dydrogesterone definitely works. So I'm using it from last 3 years for recurrent miscarriages, but I do stop after 20 weeks.
My friend Umarai, Dr. Surjeet Kapoor.
It was very well said about the tender loving care, of course, is a very, very important thing. And I think tender loving care is much more in India than
Uma, people want to
abroad.
see you. Uma, people want to see you also.
Okay. Can they see me now? Am I visible?
No.
No? But I can.
चलिए बोलिए बोलिए.
So now
You need to click twice on start video. Once you click,
Okay.
yes, now
Okay.
Now you are visible.
Now you can see me?
Yes.
Yes, yes.
Yeah. Yes. So I just wanted to say about tender loving care, which very rightly Dr. Sharda Jain said that is very, very important. And one thing which I don't agree is West doesn't give that much of tender loving care. As
I also say the rest does not help.
As the Indian doctors give. Indian doctors, I mean, let me be very, very clear. In the private sector, I think everyone will agree that one is really all for that. Still, the patients are not satisfied. Let me be very frank about it. But yes, very rightly, Dr. Sharda Jain said that tender loving care along with digestion is very, very important thing which we need to. And of course, the investigation has to be done so that we can find out if there is any other cause for the thing like cervical incompetence or anything else is there, or congenital malformations. That has to be ruled out. And that does work wonderfully. And with the Indian doctors and gynecologists, it is even much more.
Good.
I also just feel this thing that tender loving care is the most important part of every subject, for every subject, not only recurrent pregnancy loss. And I always feel
And
like I feel there are number of nursing homes in this line where I'm just doing a practice here. So I say whatever patients we are getting because of our behavior.
Yeah.
Because actually everybody is treating in the same, almost in the same this thing lines. They are evaluating, they are doing everything. Commonly, all qualified doctors that the treatment is same, evidence is same, all guidelines are same for everyone. You may remember, you may not remember it. The only one thing which differentiates between us is that is how you care for the patient. Once you say, basically all of us are very emotional persons. We also need, for every day we also need to be loved. Who's there, who's not feeling happy with that they are being loved? They should have a good sense of being loved also. So if you are loved from every part, your productivity increases, your efficiency increases, your work this increases. I always say to the patient, what we get from the patient? We get our living from the patient. Like whatever living we are doing, we are just getting in terms of money. Those who are working in government hospital, they are taking salary and we are taking money from the patient. What we are giving life in that. So they are giving us our living, we are giving them life. So that has been very important part. And normally our professors used to say, whatever the disease you are suffering, even we are suffering from like life-terminating diseases, like we are suffering from malignancies, cancers, 80% is an organic cause, 20% is a mental. Every disease has a 20% psychological part in it. That has to be taken good care for this thing. So sometimes the result changes because of that good, tender, loving care. That is very important. And madam has addressed every issue, like we have to reassure the patient, we have to give the time, we have to give everything. Here I just want to explain what madam said, that the shared plannings. in whatever we are doing with the patient, whatever we are describing, whatever the test, whatever the investigation, we have to be together with the patient. In some places where patients not able to afford these kind of tests, we should really help them. We should really ask, like if ultrasound is done at my place, it is okay. And the much of the ultrasound is that we don't charge. Even if doing it weekly, patient is not able to give your fees weekly, I just give my fee also. At one time you give it, or second time you do not give, I do not mind it. And sometimes you can request the person, the lab, or anything, please do some concession to this patient. That has to be sure. That has to be honest, togetherness. What we say for healthcare professionals, seriously willing कि मुझे इस पेशेंट को हेल्प करनी है तो मीन्स करनी है by any means. And like liberal support होना चाहिए. तुम्हें रात है, दिन है, आधी रात है, you just give me a call. What madam said, a call away. It has to be sincere. Means if you are there, you have to be there. आधी रात में कॉल कर रहे हैं, चाहे उसको हम फायदा करें नहीं फायदा करें, उसके साथ हमें उसको फायदा है कि नहीं है, it doesn't matter. But if I am standing over there, madam must be remembering Professor like Urmil Sharma said once this thing. The only one thing you can do with the best for the patient is be associated with the patient every time. It's a day, night, every time she calls you. If you are saying, you have to be honest. Either way, you do not say that I am there to support you every time, day, night, midnight, aadhi dukhan, kuch bhi, I'll be there for you. This one alone is going to give a good mental support to the patient, and she will not feel let out. So one should not feel let out this thing. So they have to be very sure about all these things, in that whatever we are saying. And shared planning, I'll just tell you one story of this thing, recurrent pregnancy loss. Although I have done for myself, it is not done for the patient. I'm very honest to say it was done for myself. Patient has lost, after 2 missed abortions, she lost 120 weeks of pregnancy. Like patients are near neighbor in the same colony she's residing, and very supposed to be very faithful patient. But we all know whenever something goes wrong, the things go exactly opposite what you were expecting from the patient. That is commonly we are all experiencing this thing. When she had IUD at that time, 20 weeks ultrasound done, and it was IUD. And the patient's ka pura chehra hi change ho gaya towards me. Like aisa ho gaya jaise ki something has been done, I have done something. At 20 weeks, what can you do? You have done an anomaly scan, it was normal, and 20 weeks suddenly patient comes with a loss of uterine. She had just come for the checkup and there was no heart sound. And it was unexplained IUD. And I seen the face of the patient that was not very happy. Then I requested them that you go for a autopsy. That you have to go for the fetal this thing. They said, no, we cannot afford this kind of quality. We have spent too much of money on the checkup, on the ultrasound. Now we cannot do it. I say you go for the checkup because it is going to base. It is your future which is going to decide what to do in your future. Otherwise, आज आप नहीं कराओगे तो कल भी हमें नहीं पता लगेगा कि हमें क्या करना है. तो बहुत पेशेंट कन्विंस करने के बाद ये कन्विंस किया गया कि I'll give you half of the money. अगर फाइनेंशियल वाली खाली प्रॉब्लम है, I am going to give you, क्योंकि मुझे कहीं ना कहीं लग रहा था this is going to trouble me. अगर ट्रबल में अगर आप कोर्ट में लीगल केस में जीत भी जाते हो, but there's too much of trauma. It is not a 1 or 2 days में डिसाइड हो जाएगा कि भाई आप नहीं हो इसके लिए गिल्टी और वो नहीं, ये नहीं होता है यहाँ पर तो अपने आप से ट्रीटमेंट हो जाता है. दैट इज द बेस्ट व्हाट वी कैन डू. तो फिर मैंने डॉक्टर गंगाराम हॉस्पिटल भेजा. एट दैट टाइम वी हैड अ गुड रैपो विद डॉक्टर वर्मा. अब डॉक्टर वर्मा बहुत अच्छी बात, बहुत ज्यादा बात नहीं हो पाती, पर उस समय करते थे बात. So I just say कि I'll give you that payment. You just take micro arrest कर दो and you just whatever the payment patient gives, it is okay because उसको मैंने बोला है कि मैं करूँगी, तो I'll definitely help. I already sent my boy with them and gave the payment, and it came out to be multiple anomalies which were not evident in ultrasound, anything, nothing was. And at least I was safe, and patient was also like very happy that after that she delivered 2 cases a year. Otherwise that could have been something wrong against me. So shared planning means you have to help the patient everywhere if you really want to. तो ये थोड़ा सा मेरे को ज्यादा, बाकी तो मैडम ने सारा elaborate कर दिया. He has addressed every issue, whatever is in. But shared planning is very honest to the patient if you really want to help. Otherwise आप बता दो कि हमारे पास ये नहीं होता, we cannot do it. And जो dedicated clinics हैं, that is very important कि dedicated clinics होने चाहिए, इसके ऊपर training होनी चाहिए कि how you are going to do the things, कि क्या क्या टेस्ट जरूरी है. ये नहीं कि पेशेंट बार बार उन्हीं टेस्ट को करा जा रहा है. अब आप देखो टॉर्च की टेस्ट है, जिस डॉक्टर ने देखा उसने करा दिया, उसके अंदर प्रोफाइल के अंदर one after one it has been abandoned. जबकि तो कभी कभी you have to just plan it कि what is really required, what is not really required, and the support should be very honest in every part. So like Madam has really elaborated everything, like simple words. We should not let our patient, the summaries, we should not let patient to go into psychiatric disorder. Like they should not land up ultimately with less care, with less emotional support, and they are just landing even and from one problem to another problem. Psychiatric problems are not easy to come out. They are not easy to come out. Once you are in psychiatric, means you are under the psychiatric for the whole of your
Very
life.
rightly said, Dr.
So
Surjeet.
you,
Dr. Mala, Dr. Mala.
first part only. So my thing it is like, आपके साथ जो wash हुए, आपकी जो problem हुई, that was not my fault. But healing your wound is my responsibility. That has to understand very clearly कि वो मेरी गलती नहीं थी, लेकिन आज अगर मैं responsibility लेती हूँ तो वो मेरी गलती है. Being a healer, being a healthcare professional, today if I do not take your responsibility, means somehow, somewhere I am at fault. So healing to you is my
Madam,
responsibility.
I would like
Dr. Mala Srivastava.
Thanks, madam. You had really explained elaborately how tender loving care goes a long way in helping the couple with recurrent pregnancy loss. Recurrent pregnancy loss is definitely an untold grief. It shatters the couple, especially the mother. Because we have to understand that she's carrying the baby and she's also getting the trauma of abortion, the pain, the fear, the emotion and the stress. Only a doctor's consolation to her, counseling to her, and telling her that next time I will take care of you. I will see to it that you can get a healthy baby in the future. That goes a long way in helping them out. Definitely, I have been using dydrogesterone for long because especially of the immunomodulatory effect of the dydrogesterone, which acts at the subcellular level. As Madam Hall already said, that it converts Th1 activity to Th2 activity and promotes anti-inflammatory effect and also promotes the carrying of the pregnancy and continuation of the pregnancy. And as Dr. Anjila said, that Dr. Ashok Kumar's study had been a landmark study, and because it has been an Indian study. I just wanted to add something that 40 to 50% of cases are unexplained. But now that we are focusing both on the female as well as the male partner, now there's a role of sperm in unexplained recurrent pregnancy loss, and which has been told as controversial because by chromosome microdeletion, sperm oxidative stress, sperm's DNA fragmentation, sperm concentration, all this goes a long way in doing the recurrent pregnancy loss. So we have to also take care of the male partner when we are talking about tender loving care for the female partner, because both of them undergoes a lot of stress. And not only when we are counseling, we should not only concentrate on the female partner or the mother, we should also concentrate on counseling the male partner or the father, because he's also going through the same stress of recurrent pregnancy loss. I think we have to concentrate, as ma'am said, to couple counseling, couple de-stressing, and tender loving care to both is very important, and it goes a long way in making the atmosphere at home around the pregnancy very congenial so that the pregnancy ends in a healthy outcome.
Thank you, Dr. Mala, for touching these 2 points that, this male partner should be definitely investigated. And we have been doing sperm DNA fragmentation index, and we find significant number, almost 80% of patients of recurrent pregnancy loss have additional problems. So when both partners are having a problem, then I think that particular thing should be handled. And I also very feel, that's not the topic today. The topic something different. I find tuberculosis is seen as good in 25-30% of cases also. And once you have treated them, the recurrent pregnancy loss is not there. I can see Dr. Mittal. I want to, Dr. Mittal, if there, she should comment, and Dr. Sangeeta Gupta, in case if she's there, please comment. Dr. Mittal?
Yes. I would just like to say that the Harrison's textbook of medicine says medicine has 2 parts, the art of medicine and the science of medicine. So that is, and both go hand in hand. And the textbook mentions that this is the reason why the professor and the resident take their rounds together. The resident is better in science of medicine. The professor is better in art of medicine and knows what part of science is to be picked up. Will not use the entire scientific knowledge of his resident.
Yes.
And हमारे कितने मरीज होते हैं जो हमें कहते हैं कि डॉक्टर साहब आपसे बात करके आधी बीमारी दूर हो जाती है.
बिल्कुल ठीक है.
Yes, that is the tender loving care. So the art of medicine and the science of medicine is tender loving care with progesterone. And both of them should be given together. And I feel that when we are counseling, it's in Indian scenario, it's not only the couple counseling. It has to be if they are staying with their mother-in-law, she has to be taken in the picture and counseled that nobody is to be blamed, that the couple needs your tender loving care also. No? And many a times I counsel the couple once, and then I ask them, are you living in a joint family? Will you bring your mother in? Most of the times the mother-in-law is equally worried and she comes with the couple. And then I counsel her as well. So I feel in the Indian scenario that is important. To,
Is Dr. Sangeeta there? Sangeeta Gupta?
Yes,
Thank you very much, Dr. Mamta Mittal. Very good.
Giving giving a elaborate talk on tender love care as well as hormonal therapy. And I will say that emotional stress, psychological trauma to a couple, I mean, as well as husband and family, or to suffer a great or psychological trauma and tender loving care. Not only abortion, even in recurrent infection failure. Every field of medical science, there is a need of tender loving care. And it requires, of course, like abroad medicine that is practiced in India, that we are dealing with a quality very well
Sound is breaking.
but of course, psychologically by the doctor or by psychologist, definitely helpful, and that it is 80 in more than 80% of cases, if there is a psychological support without any treatment, and in a normal pregnancy, there is 30% without a treatment that in a normal. I agree that progesterone has got over treatment, and even in hospitals, we are giving oral progesterones in cases of abortions as well as in treated pregnancy failures, and admitting the patient, if possible, for the patient for 2 weeks in the area in the period where she had previous losses. So even in government hospitals, we are giving hormonal therapy, and we are giving rest, emotional support. So this is as far as this in government hospitals.
So I think it's a great experience sharing as far as the experts are concerned. They all supported that a tender love and care is very important. The rest is not important so much. And progesterone definitely is helpful to tide over the problem. And I feel, very rightly, Dr. Surjeet said that we should not refer them to the psychiatrist and open up other problems for them. And I think that's very important. But I think then in that particular case, this tackling of grief is very particularly important. Or guilt is very important. I have taken this kind of food, that's why I bought it. I took this kind of thing, that's why I bought it. I think every kind of guilt has to be addressed. And we are not trained into this. Only those people are trained into this. I can definitely say that assurance from all sides is very much important. This is an area, I was trying to see the recurrent pregnancy losses books, and just a mention of a page is there on tender love and care, because they expect, as Dr. Mamta said, there is a science of medicine, and there is the other side of medicine. The difference between a professor and the resident is only this much. The professor also makes mistake. The resident also makes mistakes. No professor can say that I have not made a mistake. It is only difference is 2 to 5%. But the difference is only how they handle the patient.
Yes.
So that's very important, I think. Thank you very much. The final word goes to our last and the youngest expert, Dr. Madam Meenakshi. Madam Meenakshi, any last comment by you?
Thank you, ma'am. It was a wonderful presentation, and I really agree that tender loving care can change the patient outcome. because once the patient is relaxed and satisfied and all her guilt and fears are addressed, we will be more able to handle the patient management much better. It really shifts the patient's immune response also in some way and maybe leads to a possible outcome which is positive. And if the patient is very much scared, she's always afraid of or suffering from a guilt, she will not be happy, then the chances of abortions are definitely higher. So the main thing is that the patient, all the fears and all the guilt should be addressed by the treating physician.
Yes.
And we should not be sending the patient to psychiatrists. We should be counseling the patient ourselves. We need to devote some other time, some extra time to the patient so that all her anxiety and fears are allayed.
Again, definition of tender loving care.
I have 3 patients, one patient is 41 years, conceived spontaneously, she has had 5 abortions. And, I'm crossing my fingers, she has crossed 26 weeks of pregnancy. I told Dr. Khurana, please spend 5 minutes more on her. So, he also said, things are going well, madam, aapko bas और 6 हफ्ते चलाना है, फिर तो हमारी नर्सरीज आपके बच्चे को बचा लेंगी. So, and, my last PA's sister has 5 abortions. And now for the first time, she has crossed 12 weeks. So, it is every time she comes, she will cry. And every time we have to hold her hand, don't cry like this. This is what it is. So, I think, it had been absolutely great session. Thank you very much. All the experts, Dr. Mala, Dr. Surjeet, my friend, Dr. Uma Rai, Dr. Sangeeta, Dr. Anjila, and Dr. Mamta Mittal. We've not been able to take the participation of Dr. Seema Sehgal. She's busy in OT. So, thank you very much. Tomorrow there is another presentation, another meeting from East Delhi, and that starts sharp at 3 o'clock or 2:30?
2:30 to 4.
2:30.
So we'll meet again at 2:30 tomorrow.
Now here I wish to tell doctors of all presidents who are there that, this is the time that all of you have to select out all the awardees. Few awardees name I will give, but, few awardees name you have to give. I will send it to tonight. And आपने अपने यहाँ पर लोगों को भेजना है. What are we planning is on the 16th of August, we have booked everything for all the office bearers if they could join it. On the 16th of August, we are having a physical ceremony. And the physical ceremony will be only awards, and there will not be any academic part attached to on that particular day. So I think we are all looking forward, and from your side, you need to do a little bit help to us. मोटा मैं आपको बताना चाहती हूँ कि अल्पेश गांधी and Dr. Kriplani will be getting Living Legend Award.
Wow.
People, Dr. Sangeet, Dr. Seema, you want to make it last minute comment?
Yes, ma'am.
I don't know, ma'am. आपने क्या बोला? I think it might be very good.
ये बहुत बढ़िया हो गया आज का session. The inputs from the experts had been absolutely great, and I'm sure आप तो वैसे ही tender है, तो tender loving care तो आपका एक principle ही बनाया हुआ है आपने.
Definitely, मेरा तो ma'am, I think success of my bad OH patient is just because of the tender loving care. And tender loving care is basically, ma'am, everybody speaks about it, but how many of us practice, that is a very important point. Because we have to sit with the patient, at least sit with the patient for 5 minutes and counsel her and basically shed her negativity, shed her this fear and everything. And we have to really speak something extra than the medical this thing. Because what happens sometimes, what we are speaking, it looks like we are speaking koi spirituality ki baat, कुछ शिवानी दीदी की बात, कुछ सदगुरु की बात. तो these things, they do impact a lot. And what I take it as a tender loving care, it is sort of basket full of treatment which we give for recurrent abortions. It is whatever you give, either folic acid, you give progesterone, you give immunoglobulins, you give whatever. It is sort of basket full, but you are wrapping it around with a ribbon of tender loving care. And if it is properly wrapped around, nothing will fall, and patient will be able to sail through nicely till 9 months. So it is what I take on. It is and like a rope you can hang around everything.
I feel, the husband also requires caring. बहुत ज़रूरी है.
Definitely. Because normally what we see, we expect a lot from the patient, but what we can do for her is that we can assure her that we are there for her, to help her. So together we can win. So this is what, if we can impact her in her mental this thing, because mind, body and spirit, if we take all these three aspects together, so we are normally successful in 90% of the patient, because I can count on many patients, those who have multiple abortions, just for the tender loving care and care from the doctor from whom she's not expecting a lot. And if she is also giving the tender loving care and she's saying ki, yes, I am there, tum kabhi bhi koi bhi problem is, just call me, you come over, I'll see. So that is assurance that really impacts us, the patient.
And what Dr. Surjeet said, what Dr. Surjeet said, wherever things are going wrong, must get that particular child at top sit. I think, that makes a lot of difference, and you'll find the answer is there, why this thing has faltered. So with these, I think, yes, ma'am.
Talks about the spirituality. I just want to say a single line. My mother used to say कि मांगने वाले में कमी है, ऊपर वाले को देने में कोई कमी नहीं है.
I agree with you. I fully agree with you. This lady who is
हम और आप मिलके मांगते हैं, देखते हैं हमारे मांगने में कितनी ताकत है. अगर मांगने में ताकत है, you will get it. And nature always do auto correction. Nature do cares. You do not do anything. Nature do cares, and it takes auto correction also. कितनी तूफान आंधी आ जाए, आपके लैंडस्लाइड हो जाए, कुछ हो जाए, आप एक साल के बाद जाओ, ऐसे ही हरा भरा सब कुछ हो जाता है, जैसे you do nothing. You do nothing.
Definitely. So, it is trust on yourself and in the God.
That is, he rightly said, we give us spiritual knowledge by like Dr. Shivani, by Shivani's sister, by anything. They are really impacted. She is right. They are really impacted.
डॉक्टर ये जो पेशेंट मेरा 41.5 years का है ना, वो कहती है कि डॉक्टर साहब हर बार रोती है, जब भी आएगी हर बार रोएगी. मैं कहती हूँ देखो, तुम्हारे कुछ 7-8 साल तुमको प्रेगनेंसी नहीं हुई, अब हुई है ना, तो ऊपर वाला जब देता है ना, छप्पर फाड़ कर देता है.
Yes.
तो आप उसको बस बिलीव करो.
बिलीव करो.
द ट्रस्ट इज वेरी इंपॉर्टेंट. डर का निकलना बहुत जरूरी है. ट्रस्ट एंड डर एक साथ नहीं चल सकते. So thank you very much, all of you. Thank you very much.
Thank you.
Thank you very much.
So much.
Thanks, ma'am.